Don't worry, my voice is still functional. And welcome to a lecture on joints. I've got my tablet here for writing little notes, which should be pretty sweet. And I have the camera there so that I'm not recording up my nose the entire time. So let's get this sucker started. All right, so joints are anywhere where you have a point of contact between bone and bone, or bone and cartilage. So anywhere you have these points of contact. Another word for joints is articulations. All right, so this is just an interesting thing about popping your fingers. So when you pop a joint, your knee or your fingers or anything, what you are hearing is a sudden expansion of the distance between joint surfaces. So what's happening is that there is a set amount of volume in your joint of fluid. So when you suddenly expand the distance between joints, you create sort of a vacuum, and gas bubbles pull out of the fluid in the joint cavity and become gas bubbles, and then they pop. And that is the sound of those bubbles expanding and popping. And then if you've ever known someone or are someone who feels like their joint pain responds to the weather, you have pressure mechanoreceptors in your joints. Mechanoreceptor is just anything that sends a signal to your brain in response to position. So it could be responding to a lot of things. Touch, that's a mechanoreceptor. Pressure, deep pressure, right? In this case, it's joint position. And basically, they can also respond to barometric pressure. And so there are people who actually do have joint pain when it comes to the weather. So a fun little factoid to stimulate your appetite. Okay, so roadmap for joints. This is literally just our table of contents, so we will blow past it and go into how we classify joints. So joints are classified into three basic categories on the degree of movement. So a synarthrosis is an immovable joint. So a joint that cannot move. For instance, the sutures between cranial bones, right? Those are synarthroses. So throw an E there between the last two S's to pluralize it. That's how all of these work. An amphiarthrosis is where you have very limited mobility. So it has the ability to basically deform a little. So it can deform or stretch a very tiny amount, not much at all. So for instance, the pubic symphyses, which is the fibrocartilage, right? So there's your pubic bone, as best as I can draw it. So there we go. And then the fibrocartilage between there, that's your pubic symphysis. And it can move ever so slightly. So we have immovable, limited mobility, extremely limited mobility. Then lastly, we have the diarthrosis, which you might have figured out at this point is mobile joints. So most of the joints in your appendicular skeleton are diarthroses. So, your shoulder, the ball and socket of your shoulder, the hinge of your elbow, right? The gliding movements of your wrist, right? The saddle joint of your thumb, your extremely complicated knee joint, the ball and socket of your femur and your hip and the acetabulum, gliding joints of the ankle, all that stuff. Those are all diarthroses. So we'll talk a fair amount about the knee on account of it likely being the most complex joint in the body. Now, in addition to these, we can also classify joints based on the tissue that you find in it. So a synarthrosis is generally fibrous connective tissue. So sealing together the sutures in your skull. Amphiarthrosis, that would be a often purely cartilaginous joint. So our pubic symphysis is fibrocartilage. And then your diarthroses are characterized as synovial joints, joints with a complicated structure to allow for the high degree of mobility you generally find in them. So we'll just pretend I didn't write all over that. And continue on to our fibrous joints. So there are some examples of fibrous tissue in other joints. So our synarthrosis, as we said, is this immovable joint with fibrous connective tissue between the sutures. Then we have an example of an an syndesmosis. This syndesmosis right here also has a small amount of fibrous connective tissue. This is the distal anterotibiofibular joint. So that is a syndesmosis. It is essentially just sort of mostly locked into place. So syndesmosis. And lastly, we have the gomphoses, which is a joint unique to the teeth, where the teeth intersect with or articulate with the cranial bones. So a gomphosis has fibrous connective tissue, basically sealing the bone into the tooth cavity. So there's your alveolar cavity in which the tooth sits. This is the alveolar margin. Well, actually, that's when there's tissue present. This right here is that alveolar margin that you may have learned about, which is where we have the visible articulation between the tooth and the joint. So not too terrible. So these are fibrous connective tissue joints. We have the sutures, the syndesmosis, and the gomphoses. I think I misspoke and said they're not all synarthroses. They are all synarthroses. So still recovering from being sick. So excuse me if I am occasionally scatterbrained. We divide the synarthroses into these three basic joint types. So the suture, the syndesmosis, and the gomphoses. So characterized by the fact that we have no joint cavity whatsoever, with fibrous connective tissue sealing the bones together. So, bunk. All right. Looking at sutures specifically, these are rigid interlocking joints. So you can see that they fit together like puzzle pieces, right? So that is our interlocking structure, even when you are looking at a cross section, they have that interlock there. And essentially, we have these bones that are knitted together with very short connective tissue fibers. So these continue to seal off generally by middle age. They are completely ossified. The reason that you have a joint here, an articulation, is that basically your sutures are not fully sealed after birth. So you have movable space. Generally, there is a even hollow spot. Varies in size depending on the child, fetus, or infant. Anyway, basically you have our cranial bones not fully sealed together so that the skull can grow with the offspring. So allows for growth of the head and more importantly the brain. So very important. And essentially by the time you are middle-aged, instead of a suture knitted with short connective tissue fibers, you now have a synostoses. So this is already plural, synostoses. So osteo, right, bone. So basically the fibrous connective tissue is replaced by bone. So there you go. Not too bad. Next up, a little detail on the syndesmosis. So these are bones connected by ligaments. So ligaments seal them together. Ligaments being made up mostly of incredibly densely packed collagen, providing that extreme resistance to tensile stress. So not too bad. The movement really just depends on the length of the ligament and the type of bone connection it is. So here's the synarthrotic distal tibiofibular joints. So in the front, on the lateral side there. So lateral front. So if you wanted to A and P this sucker up, you'd call it the synarthrotic distal anterolateral tibiofibular joint. Woo! That is some good language right there. Okay, so this has extremely limited movement. Basically none. You can see these bones are up against each other, and it is a very short length of ligament. So remember ligament, that is bone to bone, whereas tendon is muscle to bone. So ligaments. For a syndesmosis that is movable, right? Basically, this tibiofibular joint here, this only moves under extreme stress. Like damage due to a twisting ankle or falling or something like that. That's when it can afford a tiny amount of movement. Otherwise, this is thoroughly immovable. Whereas here's our diarthrotic syndesmosis. This is referred to as an interosseous membrane. So this is between the radius and the ulna. And it is just a membrane to help keep those bones up close, to help maintain these two joints where these bones articulate. So not too terrible. Here's our very cool image of the actual interosseous membrane there. That is technically a syndesmosis. On to the gomphoses. So pagan socket joints, as I mentioned, this is specific to the tooth. We have the alveolar socket, the alveolar margin, and the tooth is just sealed into place from the periodontal ligament, which is an extremely short fibrous connective tissue seal, which is important. You do not want your teeth to fall out when you accidentally bite on a piece of pebble that got mixed in with your grain. So generally bad when your teeth just fall out of your mouth. So the gomphosis is a very structurally sound joint, a very strong joint. So not terrible. And on we go to a little image of one of these cartilaginous joints, where we have no joint cavity. Come back here with the pin. And the bones are sealed together by cartilage, allowing some degree of movement. We have the synchondroses and the symphyses. So you'll never guess what this falsely colored light blue joint is right there. That's right, the pubic symphysis. So that is an example of one of the symphyses. All right, so let's talk about the synchondroses. So these are kind of interesting. What we have here is often part of the presentation of a different joint. So it's a little bit more complicated to describe. Okay, so wherever you have hyaline cartilage on a bone, that is a synchondrosis. They are all synarthrotic, which means immovable, right? And the reason they are synarthrotic is that these joints are actually basically sealed bones with hyaline cartilage. So right here, the epiphyseal plate is an example of one of these synchondroses. We have the upper portion of the head of the bone articulating with the lower portion of the head and the shaft there. And so we have bone meeting bone and cartilage between them, making that, and since it's hyaline cartilage, it is a synchondrosis. So we can also see that in the joint between the first rib and the sternum for a much larger synchondrosis. So here is our synchondrosis with the main bit right here where our cartilage is fully sealed into the manubrium of the sternum. So not too bad. So wherever you have hyaline cartilage sealing two bones together. And that's the big thing that's different between the synarthrotic joints we've seen before. So the synarthrosis, that is a part of the syndesmosis or the gomphoses or the suture, is fibrous connective tissue. Here we have hyaline cartilage. Otherwise, it's mostly the same concept, an immovable, sealed bone-to-bone joint. So there you go. So the epiphyseal plate is like your gold star example of one of these joints, really. Okay, so as we continue, just another look at the epiphyseal plate right there. You can see the clear delineation between bone and bone, so that is technically an articulation. And then again, the same picture of the sternocostal rib. So not too terrible. All right. Now let's talk about the symphyses. So here we have a little extra spice to our hyaline cartilage sealing bones together. So these are slightly movable, right? So they tend to be ever so slightly movable. And what they are is bone sealed to hyaline cartilage, sealed to fibrocartilage, sealed to hyaline cartilage, sealed to bone. So when you look at the intervertebral discs, right? So here's a vertebra, here's a vertebra. So we have two bones making an articulation. And we have nice little layer of hyaline cartilage sealed up against the vertebra. So there's our hyaline cartilage. And then we have that fibrocartilage disc. And this is all thoroughly sealed together. So it's all sealed together into sort of one unit. So same dealio applies right here with the pubic symphysis. You've got a fibrocartilage pad there between both sides of the pubis. And so that means that at the actual bone-bone articulation, the bone fuses with hyaline cartilage, which fuses with the fibrocartilage of the symphysis, which fuses with hyaline cartilage, which fuses with the bone on the other side. So hopefully not too terrible. There's hyaline cartilage on the articulating surface of the bone, which is fused to fibrocartilage, providing very strong bones that are flexible, but not all that flexible, making them epiphyseal. The bones that have a very slight amount of mobility. Not too terrible. So here's some intervertebral discs, right? And again, we can see them falsely colored for contrast. And we have our fibrocartilage pad. and the hyaline cartilage sealed to it. And then the boom, well, whatever, orange works. So not too bad. And then right here, there's the two halves of the pubis. So again, not too terrible, which brings us to the most complicated joints, the synovial joints. So the synovial joints are all diarthrotic. That means these are fully movable joints. These are basically all the joints of the appendicular skeleton. So, which means that it is most joints in the human body. So all limb joints, appendicular skeleton. So there you go. Not too terrible. So now on to the distinguishing features of synovial joints. So what are the distinguishing characteristics of a synovial joint? Well, I mentioned at the start that these are rather complicated joints. You will not be disappointed. So things to mention about these. They have articular cartilage. That means that there is a layer of hyaline cartilage on the heads of the long bones in the joint, or hyaline cartilage anywhere you have the bone-to-bone articulation. So, articular cartilage. Then we have a joint cavity, which is a hollow space in the joint. So, right there, filled with fluid. So we have an outer fibrous layer of an articular capsule. So the outer fibrous layer of this articular capsule kind of hard to sort of accurately represent it in there, but close enough. And then inside you have the synovial membrane that gives it its name. So this synovial membrane right here. So these are the main features: an outer fibrous layer, an inner synovial membrane. And then in order to keep this in place, you have a whole bunch of reinforcing ligaments. So to be specific with it, we have some reinforcing ligaments here and here. And then there would be others on the other side. And then you have this one right y'all. And then you will also have a whole bunch of tendons, which we will talk about. Now, the presence of all these ligaments and tendons, especially, well, ligaments are immobile outside of trauma. Tendons are by their very nature mobile because they are pulled on by muscle. So tendons experience changes in tensile strength. So they move. So in order to have a tendon move against a joint, well, you're going to need something to cushion it and reduce friction. So tendon sheaths reduce friction, especially for tendons that transit under bones. So for instance, this kneecap here has a patella sitting on top of everything, and there are some tendons that pass under the patella. So reducing friction on those tendons, extremely important. So we have tendon sheaths, right? Tendon sheaths will reduce friction when tendons have forces exerted upon them. So here you can see a ligament right here. And then in green, we have our tendon sheath. And then running through it is, of course, a tendon. So this provides a big reduction in friction. So tendon sheaths reduce friction for when tendons have forces exerted on them and move. And then you also have bursae, which are small, fluid-filled, let's just go with pads, that basically provide cushioning. So a big deal is the bursa between the patella and the knee joint. So here is our big, beautiful bursa right here, cushioning that patella so that it does not directly grind against the synovial joint. So bursa, very important. So these bursa and tendon sheaths are located where we have ligaments, where we have muscles, right? Where we have skin. There are bursae underneath the skin because skin stretches and can apply friction to a joint. And anywhere you have bones. So they are all over the place. So obviously tendon sheaths where you have tendons, but bursa are present between bones. Bursa can be present between muscles and joints, between ligaments and joints. And then you have them tendon sheaths. So all stuff to protect the joint. So this is all for joint protection and friction reduction. So not too terrible. Anywhere things rub together, you have bursae and tendon sheaths. Not too bad. Here's some basic tendon sheaths of the wrist and the ankle. So you can see in this sort of lighter blue, the darker shaded lighter blue. There on the wrist, we have a whole bunch of tendon sheaths. And in here we have along the ankle a bunch of tendon sheaths as well. Here to keep the tendon from rubbing against bone, rubbing against the joint. So great. You can see that multiple tendons are sort of held together by one overarching sheath, and they sort of all connect up with sort of one or two muscles, which is why some of your fingers, there we go, will shift together because their tendons are sort of right up with each other, wrapped up in the same sheath and inserting into the same muscles, which is pretty fun. Okay. So when it comes to stabilizing factors in synovial joints, so factors that keep a joint stable. I know this is sort of a weird thing to write, but whatever. These are factors that keep the joint stable. The shape of the articular surface itself plays a minor role. So, for instance, when you look at the knee, the most complicated synovial joint in the body, we actually have basically 3 separate joints going on here, right? So you have the medial condyle of the femur and the tibia there. Then you have the lateral condyle of the femur and the tibia. And then you have the patella and the femur and tibia. So there's basically 3 separate joints here. And you can see the shapes of the joints sort of aid in that articulation, right? So when you look at that femur, it has that sort of indented area for the patella, right? So, and then the shape of the tibial joints is aided by the meniscus, which is essentially a little cartilaginous pad that helps to create a little cup. So, creates a cup that helps keep that joint stable. Now, these things might seem very important, but they actually do play a relatively minor role in joint stability in an appendicular skeleton of a human. So, more stabilizing factors include the ligaments. So, the number of ligaments and the location of the ligaments can help stabilize the joint. So, we have ligaments fusing the excuse me. I am suddenly forgetting the opposite of distal because of course I am. But whatever that is, I'm going to think of it in a minute. But this side of the tibia and fibula, over here we have a ligament coming around the outer edge of our synovial joint here, fibula to femur. Again, just more ligaments. We even have ligaments inside the joint. So we have all of these anterior ligaments to hold structures in place. And then on the posterior side, we also have quite a few ligaments wrapping around this joint. And again, this plays a larger role than structure, but it is still a limited role. This is not the biggest feature stabilizing these joints. You might often think that it is, but I have, I think, at least 1, possibly 2 ligaments detached in my ankle. And while my ankle is weaker, it is a functional right ankle. So those ligaments are not the most important factor there. The most important factor in most of your joints is muscle tone. The stronger your muscles associated with the joints, the more stabilized that joint is. So this is especially important in the shoulder and obviously, based on the picture, the knee. So these tendons that cross the joint and then are reinforced, or these tendons cross over the joint. So we have some tendon crossing over here, and then some of it crossing in over here, over there, over to there. So sealing in there, and then right, y'all. So the stronger your muscle tone associated with these tendons, the better reinforced that your joint is. So the shoulder and the knee, extremely important. Also, the arch of the foot has a lot of muscle tone reinforcement even though there's no muscle actually in the arch, the muscle of your lower leg is where you develop the tone to sort of maintain the structure of the arch of your foot. So that's pretty darn cool. So let's talk about some of the slightly less complicated synovial joints. We have gliding synovial joints. Gliding synovial joints are where joints have angular movements, such as rotation. Oh, wait, these are the three types of joints. Like I said, still recovering and still a little discombobulated. So we have gliding movements. So joints, synovial joints can glide. So some synovial joints are for gliding. Hi, what's up? My wrist is gliding. Some synovial joints are great at angular movements. What up? Doink. There we go. Yeah, do you even lift? So there's that. Then we have rotation. And then we have a variety of very special movements. So movements that have their own special terminology for them because they are parts of sort of unique joints. So for instance, this is a supinated wrist. This is a pronated wrist. So that's a special movement, gets its own special name. You get the idea? So let's rock on to our gliding movement joints. So here we have flat bones that glide or slip across each other's surfaces. So we have a few gliding joints around here. The carpals are your big gliding joints. So the intercarpals. The intercarpal articulations. Remembering that carpal bones are the bones of the wrist. So these bones can glide over each other. So when your hand is moving like this, those bones are gliding across each other. So intercarpal joints, the vertebra, right? So if you go, oh, what's over there? Wait, I think I heard it over here. Oh, I'm gonna take a peek over there. Oh, I am gliding my vertebra. So not too terrible. Then we have the joint between the femur and the patella. So if you grab onto your patella, like so right here, and see if there we go. And now I can feel that joint getting my glide on. I honestly have no idea if my knee is in the field of view. So let's just hope. But there you go. Some gliding action. So, when memorizing these, feel free to mess with your own joints. That's probably the best way to memorize the locations of these movements and what these movements are. All right, angular movements. We have some terms for how we move at angles. Basically, if you look at a joint, you can describe the angle of the joint at rest. So, at rest, the joint is at a specific angle. So, for instance, an anatomical position, my neck is at rest. And so I can describe it at being a specific angle, this 90-degree sort of straight up and down angle, right? So in flexion, you decrease the angle of your joint. So here, if this is my 90 degrees, then looking at my chin, I'm now at like, you know, a lower angle. So 90 degrees, probably like, I don't know, 45 degrees, whatever. So that is flexion, decreasing the angle of the joint. Then we have extension, which increases the angle. So if I'm flexed, I can extend. So extension is generally considered from flexion to rest. So here I've extended my neck joint. Flexed, extended to rest. Now I'm going to hyperextend it. Wow. Oh, what's that up there? So interesting. So this is extension beyond the normal range of movement. This is potentially damaging depending on what joint it is and how strong or sudden that hyperextension is. So for instance, if you've heard of whiplash in a car accident, you're driving, someone rear ends you in the front, the forces carry your body forward, but you gain some speed and basically your neck snaps back. Your head is moving at one speed and your body's moving at one speed. The force in the car transmits the increased speed, essentially into your chair, and then your head whips back and you hyperextend. So not great. So there you go. You can flex at the waist and then extend and then hyperextend. You can do flexion at the upper arm and lower arm, the humero-ulnar joint, right? So, oh, what's that? Flexion. Welcome to the gun show. Extension. And due to the structure of the elbow, you actually cannot hyperextend without actually breaking bone because of our ulnar notch and our ulnar process. So not too bad there. You can also rock out your arm, right? So flexion, extension, hyperextension. So whoop, flexion, extension, hyperextension. Your knee, right? So your leg at your hip. Flexion, extension, hyperextension. Your knee, right? So flexion, extension, and I'm not going to go chorus line and hyperextend. You get the idea. So flexion, extension, hyperextension present in a lot of the joints of your body. So good times, not too terrible. So we shall continue onward. And I just did all this. So, woo! Okay. More angular movements beyond flexion, extension, hyperextension. With your ball and socket joints, so your humeral shoulder joint, so right here, you can do this. Whoop, and bring it back down. And then the same goes with your hip, right? You can take it here and bring it back. So these movements are going to be described in relation to the midline. So the midline of your body, you go away from the midline or towards the midline. Away from the midline or towards the midline. If I am grabbing this arm and taking it away from myself, I am abducting my own arm. Oh no, what a world, what a world. So I am abducting my own arm. It is abduction, moving away from the midline. Then we have back towards the midline is adduction. And then, special to the ball and socket joints again is circumduction. So this is moving your arms in a little cone in space. So what's that look like? Woo! So, there you go. I'm just circumducting like a badass. So, circumduction. Okay. Rotation is when you move a joint on its long axis. So here's the long axis and move it side to side. That literally means nothing, so move it side to side. Long axis, moving it along the long axis instead of the short axis, which would be flexion extension in my neck. That's the short axis, right? Flexion, extension, hyperextension. Here, rotation on the long axis. And you can do that with your legs. You can do that with your waist, right? So, and rotate left, and rotate right, and rotate left, and rotate right. And then you can do it with your leg, but that won't look very cool on the camera because I cannot fit my entire leg and foot. And in order to really see it, it's basically where you just stand facing forward and then turn your knee out to the side. So, or turn your knee in. And that is rotation of the overall leg. Rotation at the femur and the hip. And you can just do rotation at the humerus. And to know that you're rotating, right? Grab your wrist and make sure that you're not moving like this. So this is that supination, pronation. Rotation, your elbow should move. So you can put your hand forward in a fist, and then your elbow moves. So there you go. That's rotation at the humerus and the shoulder blade, rotation at the femur and the hip, rotation at the atlas and axis along that dens. So rotation on the long axis. So this is the atlas and the axis. Remembering that the atlas basically is just a little curved vertebra that holds up your skull, and then the axis is that little vertebra that connects to it and has the little rotating part. So there you go. That's your C1, C2. Not too terrible. Okay, on to our specially named movements. So, I may have said this a couple times before, but movement of the radius around the ulna is pronation versus supination. So, remember, in anatomical position, you are hands forward like this. So this is a supinated position. That is a pronated position. So supinated, palms up, or anatomical position, right? Pronated, palms down, or, not anatomical position. If you ever want to play dinosaur, it is important to remember that theropod dinosaurs, like your big carnivores with the 2 legs and the 2 arms, cannot pronate, right? So any movie or game where you're T-Rexing around like this, you are T-Rexing around with broken wrists. This is as much as they can do. So I can keep their hands at the side, maybe a little bit of motion like that. They cannot pronate. So kind of big deal there. Don't ever let anyone play T-Rex with pronated wrists, as that is anatomically incorrect. And it's important for dinosaurs to be represented correctly. I'm just saying, you should scream at children doing this. Definitely in front of their parents, walk up to them and just scream as loud and as angrily as you try, and get veins in your head to pop forward about how dinosaurs can't pronate. And don't explain to them what pronation is. Just scream the proper anatomical terminology. Just scream, supinate your wrists. And then, that'll go super good. I give excellent advice. Just wanting you to know. Okay, more special movements. We have the movement of the foot. So, this is basically moving your toes, right? So, essentially, if you want to point your toes down, like lift your leg. Let's see here. Do a little bit of this. Get my sock off. I know. Scandalous if this was 150 years ago. Plantar flex. And then it's harder to see, but your toes go up. So resting position, dorsiflex. Toes up, dorsiflex, plantar flex. So if you are trying to think about it, think about the fact that the dorsal surface of your foot is what you are trying to flex when you dorsiflex. And the bottom of your foot is the plantar surface, and that is what you are trying to flex when you plantar flex. Amazing. I defined it without breaking it down into anything easier on that last one. I basically used the words in the definition. Always the best way to do this. No notes for myself. Okay, so continuing with special movements of the foot, we have inversion and eversion. And this is literally just rotating your ankle inward or outward. So medial motion is an inversion. Lateral motion is an eversion. Keep feeling like I'm going to record myself falling off this chair and breaking my neck. It'll be just an epic final lecture. Eversion, inversion. Then we have the mandible. So the mandible has two different special directions of movement, right? So you can go like teeth, that you can push your mandible forward, and that is protraction. So if you are trying to imitate an orc with your big canines, you are get the hobbits. And then if you want to pull your jaw backwards, that is retraction. I retract my last statement. Yeah. If someone said I was smart, they would look at me and retract their statement. That's a good mnemonic. Then this next one is super easy. Elevate, lift your jaw up, depress, put your jaw down. Depress, elevate, depress, elevate. Not too bad. So these are easy ones. Continuing forward, we now have opposition of the thumb, which is literally the name of the special movement. Opposition of thumb, where you have your thumb and you have your pointer, or really any of your fingers, and you bring them forward. I have now done an opposition of the thumb. My thumb is here, my other finger is here. They are at opposite, right, angles there. Opposition, 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 opposition. So if you are trying to shadow puppet a bunny, there we go. Have to oppose your thumb and your fingers. And you can have your bunny and then sniff its little nose. Oh, that's good. That's good. And then I can, scurry away. Hop, hop. I'm getting tired. We're working on through it. Okay, so, that was the types of movements. Now let's talk about some granular details of the synovial joints themselves. There are 6 types of synovial joints based on the shape. Before you freak out, we're limiting ourselves to 4. A plane, a hinge, a pivot, and a ball and socket. Hopefully by now you all get what a ball and socket is. And the others hopefully will make sense as we go. So a plane joint is slipping movements only. So a plane joint is where we have slipping movements only. So basically when one joint slips over the surface of the other, these are gliding movements over flat articular surfaces. So short gliding movements. So gliding over flat articular surfaces. Good news, you basically know where plane joints are if you know where the knee is. That's our gold star example of a plane joint. It is doing simple slipping only. So you can see when your leg at the knee is flexed, right? Versus extended or, flexed as far as it'll go. The kneecap, the patella essentially changes position ever so slightly. When your lower leg is fully extended, your patella rides higher up on the femur. And then when you flex your lower leg, the patella is pulled, gliding down from the femur over the synovial cavity to protect it better. So kind of cool right there. So hinge joints, relatively easy. These are movements on a single plane. So again, you have your pin there and it moves along that single plane. So here is my plane of movement. My pin there representing that, and it can move along that plane. It is essentially a door hinge, amazingly enough. This is restricted to flexion and extension. So this is motion on a single plane, flexion, extension, flexion, extension. Not too terrible there. So that is a hinge joint. Your ball and socket is obviously not a hinge because it can, do more movements, but your knee has a hinge component to it. And then, of course, your humeral ulnar joint has a hinge to it. This guy's hinging his joints. So movement on a single plane, flexion and extension only. So again, elbow's a hinge. And then you can see that actual, that single plane there. And it can move along that single plane like a door hinge. Feel like I have explained this enough. And then again, your knee joint has a hinge component to it when you have your extended lower leg versus your, flexed lower leg or fully flexed lower leg. So there's a foot, there's your foot, there's your foot. I guess technically, depending on your range of motion, you can get your leg really flexed if you want to do that one dance move that I do not remember the name of it. So again, and there's your hinge, your singular plane, and your knee can move. There's your, that color is a little not great. There's your singular plane, and you can move along that single plane. Hinge. Boop, another picture of a hinge moving along. Okay, pivot joints. This is movement in one plane when you have a rounded end of a bone. So again, we have one plane of movement, and it can move along that one plane. And this is where we rotate in place. So there's a rounded end, and it rotates in place. So you can see we have this ligament here, and here we have our radius and our ulna, and we have the head of the radius, which pivots in place along that ulna, and this is the fundamental movement that allows you to pronate versus supinate. So pronate, dinosaurs are wrong. Supinate. Come on over here and I'll show you how to supinate your arm. So there you go. So generally you have a sleeve or a ring, and it rotates against another bone. So not too terrible. So here we have our ligament sleeve that holds the rounded end of the radius, the head of the radius in place. Still not remembering distal versus whatever. It's gonna come to me. So, boom. It's a pivot joint. And again, your gold star example is literally just the radius and the ulna. So, the radial ulnar joint, where we have the head of the radius that pivots in place. So you will notice if you feel the radius is rad, if you find your radius and feel it and pronate, right, that bone does not switch directions. It doesn't, like over here, these bones flip, right? You have the lateral side of your wrist turning and becoming medial. So over here at the distal end, it flips. And at the proximal end, excuse me, at the proximal end, if you just dig in there and find your radius, all it does is pivot. It does not actually rotate around the ulna at all. So find that radius, give her a good painful squeeze, and then pronate, and you can notice that that bone ain't going anywhere. It's just pivoting in place. So there we go. There's the C1, C2 rotation about the dins. So there you go. Not too terrible. All right, ball and socket joints. These can move in 3 planes, right? So you can have a pivoting style motion where it rotates in place. You can have a adduction abduction where you move away or towards the midline, and you can have a flexion extension. So flexion, extension, abduction, adduction, right? Pivot or rotation is the proper term for joint movement. It's a pivoting, because pivot is saved specifically for our example of the radius in the ulna. So we wouldn't describe this movement as a pivot. We describe it as rotation, but it rotates in place along a single plane. So now we have 3 different planes. We have the long plane, we have a posterior anterior plane, and we have a lateral plane. So, and we can move along all 3 of those planes. Not too terrible. This provides us the greatest amount of movement in the body. And again, your only ball and sockets are the glenoid fossa and the humerus and the acetabulum and the femur. So this is our femur here and our acetabulum, right? So acetabulum of the hip, head of the femur. Not too terrible. So don't, again, another picture because we like the pictures. Okay, and then there's your shoulder ball and socket. Again, just imaging of the glenoid fossa, which is right there. And then the portion of the clavicle, the portion of the shoulder blade, and then the clavicle that also helps make up that whole fossa. So there you go. Not too terrible. So glenoid fossa, and then the head of the humerus. Once again, more pictures. Ta-da! Here's a picture that has false coloring and contrast to illustrate the muscles involved. So, kind of cool. So, the knee joint is our largest and most complex synovial joint. The largest and most complex synovial joint. It strikes a balance between stability versus mobility. In other words, due to the weight-bearing nature of the knee, so it's a weight-bearing joint, when you increase mobility, you decrease stability, right? So the knee is sort of a compromise between mobility and stability. So not too terrible. There are essentially 3 joints in one synovial cavity, and I mentioned this already. We have the patella and the femur. So there's one of the joints. And then we have the lateral femoral tibular joint and the medial femoral tibular joint. Oh, that orange did not go through very well. There we go. So 3 different joints in one spot. And you can see we sort of consider the lateral and medial sort of functionally slightly different because they don't share hyaline cartilage. It's not fully going all the way through. There's a portion there where we don't have continuous hyaline cartilage all the way through. And that's essentially where the femur kind of just doesn't come into contact with the tibia. So, femoropatellar joint, 1. It's a plain joint that does gliding during flexion. We already mentioned that. Not too terrible. Right? Then we have the lateral and medial tibiofemoral joints. So this is where we have the lateral femoral condyle and the medial femoral condyle. So condyle, condyle. And these join up with the C-shaped medial menisci and the lateral menisci. And those are the little cartilaginous pads that help make a little cup shape. So right there in the bright blue are our images of the menisci. So making a little cup on the tibial surface. So you have the femoral condyle, and then you have a meniscus cup right there. So sort of helping hold that in place, providing a very minor amount of structural stability there. Non-zero, but still minor when you compare it to something like muscle tone. So you get a very, very tiny amount of rotation here. So if you hold your knee steady, then put your foot up onto its heel and then sort of hold onto your tibia and make sure that it's your tibia moving and not your ankle, you can feel the degree of rotation. So I flex my lower leg like I'm, sitting in my chair as I am now. Bring my foot onto my heel. Dorsiflex. grab my tibia to make sure that it's the tibia that's moving and not the ankle, and I can express my degree of rotation in that tibiofemoral joint. So very minor amount of rotation, and then mainly you get that sweet hinge. So there we go. The knee has a lot of muscles and tendons and ligaments associated with it. So a lot of muscles, ligaments, and tendons. So many muscles, ligaments, tendons, which means if you're going to have that much stuff wrapped around your knee, you got to have bursa. And there's 12 plus bursa, right? Those tendons are there to help reinforce that joint capsule, right? That joint capsule is very thin, and it is actually basically absent anteriorly because of the presence of the kneecap. So when you look at the joint capsule itself, you have in purple, it's basically going to be around here, but then very thin amount there, and a very small amount there. Well, went too far. So, very small amount there. It is not continuous with all the surfaces. Also, went too far. Y'all can't really show the lateral sides of that joint capsule. It would essentially be like this. Right. Then like that. So, whoop, hey, no, zoom out. What are you doing? I appreciate the zoom, but I do not want it. Where? Oh, this is super helpful. Thank you. Let me press a button here. Oh, okay. There we go. Got you back. Got you back. Get my pin back. There. Okay. Onward and upward we go. Okay, so we have that capsule reinforced by tendons that's basically thin and absent anteriorly because we have so many ligaments, tendons, and muscles wrapped around this sucker. A strongly reinforced joint capsule isn't as important. It basically just needs to keep all the fluid in there. So we essentially have it then having, excuse me, a bunch of fascia helping to hold this stuff in place. So the lateral medial patellar retinacula. Oh my. So we have it basically along here and along here underneath this muscle that I drew over. And then we have the patellar ligament right there. So the quadriceps tendon, right here, gives rise to the patellar ligament, and then the curving around, and you get this lateral medial retinacula as it curves around. You can see it right there. Yeah, let me erase some of this stuff. Boop. Boop. There we go. Lateral, medial, patellar, retinacula versus patellar ligament. My pen just shut down, but this slide is almost over with. So then we will have our pin back up because I have to friggin' shut this tablet down, which is why I don't use it in class anymore, because it keeps doing this. I have no idea why, but it does. Oh, wait. Come on now. I saw that blue ink show up. Was that my finger? That was my finger. Well, deeply disappointing that I have to do this one last time because there are 9 slides left. But there's my patellar ligament. So I did not include enough there. Ta-da. Now I included enough. There. So not too bad. You can see even more ligaments just reinforcing everything all around here. These are not the retinaculum stuff. These are just additional reinforcing ligaments. Importantly, we have our cup-shaped cartilaginous menisci. So you can see there, they have that distinct cup shape to them to, again, provide just a little guiding surface there so that the knee kind of just smoothly stays in place. A view, a superior view of the proximal end of the tibia, really showing our nice meniscus extremely well there. So this is the meniscus. If this is anterior and this is posterior, then we have the medial meniscus and the lateral meniscus, because this is the right tibia. It's the right tibia. And then this is our hyaline cartilage associated with the tibial surface there. So not too bad. We have our posterior cruciate ligament and our anterior cruciate ligament, just more important ligaments for holding all this sucker together. All right, on the home stretch, it's time for common joint injuries. So what kind of joint injuries you can get commonly? So sprains happen when your ligaments are stretched or torn. So your ligaments are stretched or torn. And then essentially, healing when it comes to ligaments is a very slow process. And it often doesn't fully heal. So if you have a small tear, they may not fully heal. You might have a damaged ligament sort of on a permanent basis. You'll get partial repair, and it is a very slow healing process. Sprains kind of suck. Sprains can reach a level of total rupture. So in that case, the ligament has become fully ruptured, and essentially what you have is the ligament torn away. So it's torn away from the joint. It is separated. This is a surgical repair situation. This requires surgical repair. So sprains can be minor and they can be very bad. And this is because you have ligamental issue. All right. Okay, so the next issue is when you have a tear in the cartilage itself. So this is often due to compression damage. So for instance, if you have a sudden downforce, so you can get cartilage tear, and for instance, in the knee, if you jump from too high and you land with too much force, you can get a compression injury. You can also get cartilage injuries from compression if you fall in like a sitting position and take the impact through your spine. So those are compression injuries, and that can rip cartilage. And then shear stress can also rip cartilage. So when you have shear stress, that would be like if you had your femur and you had your tibia, right? And you had your meniscus cup there. And shear stress would be stress against the cartilage itself. So if your leg sort of collapsed laterally, you could put a bunch of shear stress on the cartilage and damage it. Leg stress, the meniscus is one of the biggest issues. So you can have cartilage tears in the meniscus. Another big one where it can be a huge problem is cartilage tears when it comes to your intervertebral discs. So a ruptured disc is a rip in that cartilage so that it doesn't properly pad the vertebra. So big problem with this is that if fragments of that torn cartilage remain in the joint, they may lock up the joint or bind it. They can immobilize the joint, which is rather dangerous. You don't want your knee to suddenly lock up. Problem with a torn meniscus is that it rarely ever gets repaired naturally. This is because cartilage is, if you remember, avascular and not, it is non-innervated. So innervate means something very different. It is not innervated, which means that it doesn't have a nerve supply. So you don't have a ready nerve supply to sense the damage and dispatch healing cells. And it's avascular, which means you don't have like a cascade reaction to damage either. So this means that rips and tears rarely ever repair themselves naturally. So you generally require arthroscopic surgery for this sort of thing. And then we have strains, which are different from sprains. These are muscle injuries. This is when you, quote, pull a muscle. This is technically not an injury within the joint, but remember, it's that the muscles, right? Muscles are what stabilize the joints. So a muscle strain can affect the joint and reduce stability of a joint and make a joint more prone to injury. So it's technically not a joint injury, but it has major impacts on the health of a joint. So essentially this occurs when you have excessive stretching and possible tearing of a muscle or tendon. So excessive stretching and or tearing of a muscle or tendon. Often this can be associated with hyperextension. So when hyperextension becomes at a level that is dangerous, it strains the muscle. So that's the big danger about something like whiplash hyperextension, is that it occurs quickly enough that it can strain the muscle, damage the muscle or tendon. And so this has consequences on joint stability. So negative consequences on joint stability, which means it can lead to further injuries. So, not ideal. So there you go. There's a meniscus rip. If you have a sudden lateral impact, it can rip the medial ligaments and the medial meniscus. If you have a sudden medial impact, it can rip lateral ligaments and lateral meniscus. So danger for ligaments. And any kind of sudden impact will also pose a risk to the anterior cruciate ligament as well. Okay. Continuing on near the end of our common joint injuries. Right now, let's talk about a luxation. Luxation is dislocation. So luxations are the proper medical term for dislocations. A luxation of a joint is when a bone is forced out of alignment. So you can see here, we have luxation of a digit here, in which the distal and medium phalange have been knocked out of alignment, generally due to some kind of force, like a sudden impact, like if you're falling. So serious falls can lead to this. So generally we have comorbidities, which is your fancy medical term for occur together. If you have suffered an injury hard enough to luxate a joint, right, you're generally going to see sprains in the ligaments holding that joint stable, inflammation due to the rip of tissue, and joint immobilization because the bones are no longer articulating properly. So, very dangerous. This has generally, this is, it can be caused by serious impacts. So right here is a total luxation on the left side that I am circling. And then we have the alternative, the subluxation below luxation. In other words, a partial dislocation, which is what we have here on the right side. So that is a partial dislocation. Leading us lastly to our, well, not quite lastly, but we are so close to done. We are now at slide 59 of 63. Woo! And we have bursitis, which is pretty simple. Bursitis is inflammation of a bursa. So this is where you have some kind of inflammation, injury, generally associated with like tissue around the joint capsule or an infection, and you get bursitis. So right here you can see that redness there. That is literally just inflammation of a bursa. So it can be associated with infections. More often though, you're going to see it associated with friction injuries or impacts. In other words, something that causes damage to the tissue around the bursa. Bursa rarely rupture. So, but you can get inflammation of the tissue of the bursa. So, continuing on with sucky inflammation, we have tendonitis. So again, inflammation, amazingly enough, who could have thought, of the tendon. This also includes the tendon sheath. So inflammation of a tendon or the tendon sheath. So again, you're talking about generally overuse of a joint. So overtaxing a joint, overuse. This is where we find a lot of repetitive motion injuries. So the injury that you get from using a mouse and keyboard too much, that I have suddenly forgotten. Shout out.
What?
This injury, ligament or tendon. This tendon injury, tendonitis, right there.
Oh no, I don't remember.
Ah. It's what you get for using the computer too much or doing art too much. Okay. Whatever. Carpal tunnel syndrome. Carpal tunnel syndrome is associated with tendon inflammation and the fact that that tendon will rub up against a portion of bone. So you have inflammation of a tendon and tendon sheath from repetitive motion injuries. So there you go. Then we have arthritis. This is the most widespread inflammatory condition in the U.S. There are basically two forms of arthritis. We have osteoarthritis, which we'll mention in a second, and rheumatoid arthritis. So, osteoarthritis, rheumatoid arthritis. Arthritis in general, most widespread crippling disease in the U.S. It will cause damage to the joints, and it can cause permanent damage to the joints. Your symptoms, pain, feeling stiffness in the joint. Really, joint stiffness, swelling especially is more of a sign. Pain and the feeling of stiffness is your symptom. In case you have forgotten, a symptom of a condition is felt. It is subjective. You feel it. A sign of a condition is objectively measured. So you will feel stiffness in a joint, whereas a physician's sign would be reduced mobility in a joint. You can get an acute form of arthritis. Acute generally refers to a short-term illness. So, for instance, the 24-hour flu is an acute illness. You can get arthritis, an acute form of arthritis, from infections and certain antibiotic treatments. So, you can get it from infections, and you can get it from some treatments. So, it can also be a side effect of certain treatments. So, for instance, Lyme disease, the antibiotic used in Lyme disease treatment can cause arthritis. And if you abuse that antibiotic, you can end up causing chronic or permanent arthritis. Chronic forms of arthritis, long-term conditions, osteoarthritis, rheumatoid arthritis, gouty arthritis. Gouty arthritis is caused by the gout bone spurs forming around and in joints. So the bone spurs form in the joints, reduce mobility, cause damage to the joint, cause inflammation in the joint. Arthritis is inflammation, itis, itis, inflammation in a joint, arthra. So, joint inflammation. Inflammation can cause damage. Long-term inflammation is associated with ruptured cells and scarring. So, a long-term chronic inflammation of a joint will reduce mobility of that joint and cause a lot of problems. For instance, with osteoarthritis, the articular cartilage begins to break down, which puts you bone on bone, and that will lead to bone degradation. The bones degrade in the joint. And as the bones degrade, that causes further friction, further grinding the bones, leading to reduced bone mobility. So very dangerous as your articular cartilage breaks down. Sometimes when your bones degrade, they expose sort of jagged bits of bone. So that hyaline cartilage, keeping that very smooth, right? It breaks down. And then as it breaks down, you get bone on bone, and it can cause sort of pointy damage. So you get these bone spurs that form. And the bone spurs grind against each other and cause further bone degradation. So osteoarthritis is a long, slow road to joint immobility. So it is caused by lifetime usage of a joint or damage. So the degradation of the bones right there, that's causing a lot of our inflammation, which further degrades like the joint capsule and other tissues. So this is really a systemic issue in the joints. Once you have osteoarthritis in a joint, really the one thing you can do is eventually get a joint replacement. Joint replacements are temporary. So if you get one relatively young, you will eventually need another. A little bit scarier than osteoarthritis, which is generally associated with sort of breakdown of joints with old age, or often associated with obesity, putting too much weight on joints. Contrasting osteoarthritis, which has a lot of preventative factors you can do, lead a more active lifestyle, get a healthier diet, lose weight, reduce overall inflammation in your body with sort of a strict calorie control diet, low red meat, that sort of thing. Can do a lot to treat and prevent osteoarthritis. Rheumatoid arthritis is an autoimmune disorder. So in this case, what that means is the immune system is attacking joints. So this is going to cause inflammation of those joints and all that stuff. The articular cartilage is going to break down due to inflammation. The bones are going to grind, causing more inflammation. You're going to have scar tissue forming. You're going to have bone scarring. You're going to have potentially the healing of bone just fusing the bones in the joints, right? Since there's no real lifestyle things you can do to stop your immune system from trying to kill your own joints, basically what you have to do is medicate the symptoms. So you take medications. So that will involve pain medications. And you can also take medications that basically reduce your immune system's effectiveness. So anti-immune system. So immune suppressant medications. This is, of course, dangerous in and of itself because you will be more susceptible to pretty much any kind of parasite or infection. So you will get infections a lot more easily when you're immune suppressed, and that kind of immunodeficiency can lead to a reduced ability to fight them off. So comes with its own potential hazards. So gout, in case you're unaware, is caused by excess uric acid in the body. So excess uric acid. So this is in the blood, and it generally forms crystals in joints. This is gout. And those crystals will act much like the bone spurs. So you'll form these spurs of crystals in the joints. Good news on that is that uric acid crystal spurs are not bone spurs. So if you catch it, you can just take medication to cure your gout. We have medications that can just break down uric acid crystals. So that's good. Hooray! Not too terrible. So here's some osteoarthritis. You can see we have exposed bone, damage in there. So pretty rough. You can see a lot of rough surfaces here that are associated with that osteoarthritis bone breakdown. So not great. And this is a hand that's been deformed by rheumatoid arthritis, so long chronic rheumatoid arthritis. Here we can see fusion of a joint. There's joint fusion all over here. Here we have essentially a joint that's gotten inflammation so bad that it's luxated. And you might even get some bone fusion if you're unlucky. So this kind of arthritis causes long-term permanent damage and is kind of impossible to treat, which sucks. And that's the last slide. So ending on a high note. that's finally it. That's the lecture. Good night.